Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Jerome Leis, an infectious disease physician and medical director of infection prevention and control at Sunnybrook Health Sciences Centre in Toronto, discusses changes in perioperative practices to prevent post-operative infection. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Well, thank you so much for having me. It's really been a great trip and a lot of fun yesterday evening. This morning will be a bit different, more clinical and more IPAC focused, but you'll see the QI theme kind of throughout some of these topics. I was asked to speak about sort of perioperative practices, obviously within the wheelhouse of anesthesia, and really with a focus on prevention of post-operative infection. All right, these are my disclosures. All right, so as far as specific objectives, I'm going to go through a few examples of new perioperative models of care that can prevent postoperative infection, just kind of what is new. And I'll even touch on some latest guidelines and some of the newest things that we've implemented in my hospital. And I really want to kind of focus a little bit from the QI lens on how do you implement these things and then how do you sustain them in practice. So the first HAI, healthcare associated infection, that I'll focus on, of course, is surgical site infection. This is a big focus, I think, for all patients going through the operating room. And so, as I'm sure this group is well aware, SSIs are the third most common cause of hospital-acquired infection. Their overall incidence is about 2% of all surgical procedures, obviously much dependent on the type of procedure and the type of risk factors. But in general, you can see that this is a very, very costly complication when it occurs, obviously horrible for the patient. With wearing my infectious disease hat, it's a lot of our clinical practice is managing SSIs. And we unfortunately sometimes even see deaths related to SSIs, which are particularly tragic when patients came in walking well for an elective procedure, et cetera. And as I'm sure this group is well aware, we think about SSIs in different ways. They can be superficial. You can see deep incisional SSIs and then organ space as well. So I was actually asked specifically to focus a little bit around antibiotic prophylaxis. So here's a picture of what surgery looked like back when we didn't have antisepsis and didn't have prophylaxis. And of course, the risks of morbidity, not just morbidity, but mortality from surgery were obviously much higher. This has been obviously a game changer over nearly the last 100 years. And yet there's been a ton of work that we have learned, particularly over the last just most recent decades, about when prophylaxis is important, how best to administer it, and of course, how to optimize its use. So there are several issues when it comes to prophylaxis. It's giving the right antibiotic to the right patient at the right time for the right duration, right? Those are all the specific antibiotic-related issues. And I'm going to try to touch on each of these today. Obviously, the right antibiotic pretty much depends on the procedure, right? And what organisms you need to worry about. The right patient, I'm going to be talking a little bit this morning about specific issues about patients related to, for example, the reported allergy. We've done a ton of work in this area that I'm excited to share with you. And then maybe the weight of the patient, which could also influence that. And the right time, so the timing of the first dose relative to incision. I'm just going to throw a little softball out there to the crowd. What is the best timing for the first dose of antibiotic prophylaxis? Any takers? What do you think? What does the evidence tell us? I mean, you definitely want to remember to give it. And it's been something that we've looked at in a number of studies. And one thing that we have that is clear is that you can give it sort of too early, you can give it too late. So if you just remember to give it and whoops, this procedure has already started, you have not achieved the benefit that you want. So, the best answer is we often talk about giving within 1 hour of incision. And ideally 30 minutes is even probably better, but 1 hour is the more kind of accepted, I'll say easy, feasible kind of way of doing this. And sometimes there's different ways to do this. I don't want to, I know I'm speaking to a crowd that does this every day, but sometimes it's often, first dose, as they're basically being called to the OR so that there's lots of time before the actual incision happens. And then the right duration. Well, we'll talk briefly today about repeat dosing. When do we think about that? And the role of post-operative antibiotics, ever more controversial. I'd love to learn a little bit about what you're doing here in Saskatchewan in that area. All right, so the right antibiotic. I mean, we could go procedure by procedure and then we would all fall asleep. And that's not my job. I'll leave that to anesthesia. We think about antibiotics just at a high level, in terms of the different antibiotic coverage that we need. The best reference that we still use at my hospital is the Bratzler guidelines that you may be seeing some nods aware of already. And we think about, when do we need anaerobic coverage? Our go-to agent there is going to be metronidazole, not clindamycin. Definitely a superior anaerobic agent, better adverse event profile. If we need enterococcal coverage, we'll think about ampicillin. It's pretty uncommon to actually need the enterococcal coverage. And then if we need gram-negative coverage, we think about adding aminoglycosides. Those are all kind of add-ons. But the backbone of surgical site infection prophylaxis in 2025 remains cefazolin. Cefazolin. It's the most superior agent. It's a bactericidal beta-lactam. And multiple studies showing its superiority over other alternatives, as we'll talk about. So this is not a comprehensive list, but the right antibiotic. This is now we're going to start with the non-allergic patient who's not MRSA positive, which I'm sure we can talk about in the Q&A. Our backbone is going to be cefazolin. If you just go through all of these procedures, you're going to be using cefazolin basically in every procedure. GU procedures, you may consider Cipro. There's some data there depending on your baseline resistance rate to things like E. coli. And then plus minus metronidazole is going to be the most common add-on depending on the procedure. And as I mentioned, ampicillin and aminoglycoside addition is pretty rare to need, sort of the third line of prophylaxis. So far, so good. And so why is cefazolin preferred? This is what I want to spend a bit of time on. I kind of alluded to this. It has, you can see the references there. It provides adequate coverage for most common SSI pathogens. Actually, we think of cefazolin as a gram-positive agent. That's true, but it actually has significant gram-negative activity as well. It's actually a much broader coverage than is appreciated. And of course, it'll have bactericidal activity against some of the most common organisms being beta-hemolytic streptococci, Staph aureus. We know, and there's a lot of data, and I'm going to be talking about this, that when you use anything else but cefazolin, be it clindamycin, vancomycin, you're going to see higher SSI rates. And there are issues that are logistical issues that are real. And this is the intersection between QI and research. You could do a perfectly controlled study of vancomycin and you'd be like, oh, actually, it's not that bad. Try giving vancomycin in the timelines that you need because it's not less than an hour. It needs to be given earlier than that in order to be at optimal levels for the procedure. And because of that, it frequently, very frequently, will be given incorrectly and lead to very, very low tissue levels. So for the practical realities as well, and the fact that vancomycin is actually not as bactericidal as beta-lactams, it just is clearly inferior. We always think about vanco as the big gun. It is not. All right, so what about those who report a penicillin allergy? So as we know, and as you know more than anyone, common question you're asking every patient as they get wheeled into the OR, 1 in 10 are telling you they have an allergy, on average. Could be as 1 in 5 in some populations. So this has been looked at in many, many studies. The second one is from my group below. Essentially, the 30-day SSI rate in people who have a reported penicillin allergy is nearly twice as high. Look at that rate, 7.3% as compared to 4.8%. This was a very high-risk population in my hospital. And there have been 2 cohort studies that have done a pretty thorough adjustment for other confounding factors. The Blumenthal study, if you don't know Blumenthal, she's a big name in the allergy world, works at the Brigham and Women's in Boston. And then our group as well. We found almost identical adjusted odds ratio, about a 60% increased odds of surgical site infection after you adjust for all these other covariates. So this is a big deal. Now let's kind of dig a little deeper and think about the why we sort of avoid cefazolin in people with reported penicillin allergies. It turns out, and of course, when I went through training, and I think many others that I look at in the room that have some gray hairs like me, or you may see that you may have been told and taught that, oh yeah, the cross-reactivity rate is as high as 10, 15%. I even heard 25% if I think back. And the reason that we were taught those numbers is that the previous products that were used frequently were contaminated. And because of that, these older studies found higher allergic cross-reactivity to different cephalosporins. But these are old studies back to the 70s. In fact, more recent data suggests that I'll talk about that we actually are unnecessarily avoiding cefazolin when we need to. And so if you're able to give cefazolin despite the reported allergy, their increased SSI risk goes away. It vanishes. And so that's great news. And even better news is, as I was alluding to, cefazolin is actually in 2025 considered to be a non-cross-reactive with penicillin. The newer products of cephalosporins don't have the same issues from the previous studies. And in fact, it's been well shown, and it's now the consensus from an allergy perspective that we can actually talk about it as a non-cross-reactive agent. This has been a game changer. So why is this? It's because if you go back to, again, medical school or biochemistry, and you think about the beta-lactams, and they have their beta-lactam ring, you've got basically a side chain, right, to that ring. And it turns out that the side chain for cefazolin is completely different than the side chain that you see with penicillins. I do want to put in a small caveat there. Cephalexin, which we always think of as the same drug as cefazolin, does have similarities in its side chain. So while cefazolin is non-cross-reactive from the allergic perspective, cephalexin has a small amount of cross-reactivity. So for ID practice, when we're like, oh, they're fine on cefazolin, we'll transition them to cephalexin, we still actually need to consider the nature of their allergy before doing so. But in the OR, where you're giving the IV version of the first generation cephalosporin, it is a no-brainer for people who have reported penicillin allergy if that's all that they have. So this is great news. Now we have a target that we can address to try to reduce SSIs. So this is a look at my hospital and sort of the pre-anesthesia clinic. And I just want to share a neat project that we did over the last few years looking at trying to optimize the use of cefazolin in the population. For those that were at the rounds yesterday, you're well familiar with the aim statement that we like to use to try to guide projects, and the quality domains. We always identify which domains of quality we are addressing in each project. So at baseline, this is 17 respondents from anesthesia before we started the project. In a patient with a history of penicillin allergy, with what type of reaction would you be comfortable with giving cefazolin for preoperative prophylaxis? And by the way, this was just done just before the pandemic. And basically, as you can see, nobody's comfortable giving it for laryngeal edema or anaphylaxis. Maybe angioedema, bronchospasm, they'll consider it. But basically, they're only giving it for people who have very non-severe or non-allergic reactions. And so clearly, we have an opportunity here because we actually should not be shying away from cefazolin for a severe IgE-mediated reaction to penicillin because it is not cross-reactive. So we came up with this way of standardizing prophylaxis. Basically, we call it the accept tool. Your patient presents with a beta-lactam allergy, if you can see my cursor. The first question is, was the reaction a non-IgE-mediated reaction? And you can ask that question in a variety of ways. Was the reaction severe, blistering? Was there organ damage? Were they hospitalized for the reaction? That's a really key question, because if you have anaphylaxis, you come into emerge, you get a shot of epi, you go home. If you get hospitalized, probably something more severe, that needed to happen. And so those are some screening questions. If the answer is yes to those, then everything I just said is off the table, because these non-IgE-mediated reactions, right, delayed hypersensitivity or so-called SCAR, severe cutaneous adverse reactions, those don't have predictable cross-reactivity. You just avoid. That's a non-stop, or that's a hard stop, I should say. But if the answer is no, and we even will acknowledge unknown to the patient, and the reason we did that is because generally if neither the patient knows, because recall is really bad with allergies, as this group well knows, and the family doesn't know, probably the assumption is that they didn't have a severe reaction. The recall is a lot better for those types of really bad reaction. So then the next question is, well, was the offending agent actually cefazolin? Because then we're not talking about cross-reactivity, we're talking about direct allergy to that agent. So of course, if the answer is yes, we can clarify that the nature of the reaction was actually an IgE-mediated reaction. So these are the classic symptoms. If yes, then avoid. But if no, well, they probably had a little upset stomach with cefazolin, or there's no red flags that would tell us we can't use cefazolin. And so basically you end up giving it. Now, most patients will basically screen negatively for these three simple questions, and we'll be able to proceed and give patients cefazolin. That includes, as you've figured out, someone who has rip-roaring anaphylaxis to penicillin, documented. We will proceed. So here's a look. This is a cool chart at the practice within anesthesia before and after. On the left, you've got baseline. On the right, you have during the intervention period where we rolled out the accept tool. So at baseline, very similar to the survey, you can just scan the red bars and you can see mostly we're giving it for rash. We're definitely going to avoid it for anaphylaxis, right? And we're going to use alternate agents. And you can just see the shift in practice. There's still some people where we're avoiding. It's just natural sort of human tendency and comfort level in practice. But there's definitely been a shift in practice away from the non-severe reactions and much more, I want to say that's turquoise, much more turquoise, showing that we're giving cefazolin more often across these reactions. How does that translate into terms of overall use? For those that were there last night, you're well versed in the statistical control charts that we like to use in quality improvement. At baseline, similarly, we're giving 40% of people with self-reported beta-lactam allergy cefazolin for these elective surgeries. And as we rolled out the accept algorithm with reminders, you basically can see that we actually got that number up to close to 90% of people getting cefazolin. So does this work elsewhere? In fact, it does. So Michael Garron Hospital down the street learned about this, and they were actually looking at this themselves. And so they rolled this out slightly differently. They actually did it with what they called a rash assessment. Rather than have the anesthetist ask the screening questions at the time of the OR, rash was actually a pharmacist that played this role perioperatively. And then they basically took that as the golden assessment. The rash assessment was done, and it was basically implemented in the OR. You can see the improvement in that they saw in terms of cefazolin use using rash. What about University Health Network downtown? Sure enough, so they've implemented a number of changes, and they basically took the accept tool that we had implemented. They called it the M-accept, modified accept. The cool thing about them, and this is be relevant to the Q&A today, I think, is that they had an OR system that's essentially a CPOE, and they were able to implement decision support. So they basically took the tool that we were just checking off manually with pens and paper, and they actually built in the questions so that the decision support would take you through the accept questions, and the ultimate result of the accept questions would result in the prescription of cefazolin being ordered. So it's completely... Oh, sorry. Thank you. Computer-based order entry. So basically meaning that you can actually order your cefazolin into an OR, electronic medical record, and you can put in a decision support element to guide you on the best agent to use based on these standardized questions. So here's a look at their tool, basically, that was implemented at the University Health Network, Mount Sinai Hospital. And so here's a look at their results, very similar to ours, and they're basically in the same range. So now we start to think about, well, what is our target? What should we be doing from an anesthesia perspective? Multiple hospitals now are showing that among people who report a beta-lactam allergy, at least 80% and probably 90% of patients should still be getting cefazolin. That should be our target. And look at where everyone started. We all started in the 30s and 40% until we implemented this standardized approach. All right, I'm going to shift gears to weight-based dosing. I don't know if you practice weight-based dosing or not in cefazolin. I'm seeing some, or in cefazolin, in anesthesia. I'm seeing some nods, so I won't spend too much time on this. I would just say that what's interesting is that there's mixed data around weight-based dosing. Clearly, there are higher risks of SSIs in the orthopedics literature when you give underdose cefazolin, so 2 grams in a patient who has an elevated BMI, or definitely a weight of 120 kilos, which is sort of the magic cutoff. At the same time, we haven't really seen that in some other specialties. For example, general surgery, there was a negative study. We don't have an RCT, to my knowledge, to really compare these different weight-based approaches. I think we need one. But certainly, in general, most hospitals are moving to 3 grams of cefazolin for the preoperative dose for patients who weigh more than 120 kilos. And that's something else that can be standardized and potentially optimize SSI rates. What about intraoperative dosing? Well, of course, it depends on the duration of your surgery. The general recommendation is to redose at 1 to 2 drug half-lives. So for cefazolin, that basically means you're redosing Q4 hours intraoperatively, obviously relevant for longer procedures. Need to obviously think about blood loss, renal function. Patients with CKD may not have to be redosed necessarily based on the impact that will have on half-life. What about post-operative antibiotics? Any role? This has been an area of increased scrutiny from an international perspective. So you may be aware that guidelines before the pandemic, I always use kind of BC as my timeline because that's how my brain has been rewired. But so before the pandemic, there were JAMA surgery guidelines that came out that basically said, you know what, we should be discontinuing routine use of post-operative prophylaxis. And there was a little bit of pushback where I work for some types of procedures where they looked at the evidence and they said, well, I don't know if that applies to my surgical patients. In general, there was a lot of procedures we were able to do away with. And there are subsequent studies that came up there, some of the references are there, that clearly show that people who get post-operative antibiotics, first of all, have no benefit. Their SSI rate does not decrease. But there's clearly a signal of higher risks of C. diff, acute kidney injury, which a lot of beta-lactams can do if you give them, and that's something that we do, and a risk that we accept when we're treating, but for prophylaxis purposes is very unfortunate. They have a higher risk of acquiring antimicrobial resistant organisms. And the last thing here I have is they make antibiotic stewardship pharmacists unhappy. And I say this, obviously, in a joking way. In seriousness, I will tell you that it's so vital, and I'd love to talk about this in the Q&A, to have a really great, productive, and collaborative relationship with your antibiotic stewardship team and with your infectious diseases team between anesthesia and ID and stewardship. It's something that I'm really proud of at my hospital. It's a relationship that we've built over many years, where this is exactly the perfect topic to have a meeting about and talk about, okay, well, let's go procedure by procedure. What's the evidence around post-op antibiotics? Where is it helpful and where is it not? And where can we agree that we should be discontinuing it? And because of the risk is greater than the benefit. And that's probably most procedures, with only a few different exceptions that I can talk about if people are interested. All right, so I have heard that in Saskatoon and possibly across other hospitals as well in the province, you are implementing, in the process of implementing, an OR-based electronic medical record. Really exciting times. This is the perfect opportunity to start to hardwire the changes, the standardized approach that we know is best based on literature, putting that in to, similar to what University Health Network did. There are things that you can bake into a system like this. You can have procedure types that are specifically recognized that will auto-populate the best antibiotic prophylaxis for you. You can have the serum creatinine, their ARO status, so whether they have MRSA or not being the main consideration. You can put in the decision support layers using something like the Accept tool. So you can basically spit out the best antibiotic prophylaxis agent. You can have the patient's weight. I should have mentioned that. So here are two examples from the UHN. You've got craniotomy awake, cefazolin 2 grams, 3 grams if weight greater than 120. Done. Here's another example. Radial artery left incision, antibiotics not indicated, because there are procedures that just do not need perioperative prophylaxis, right? Harvest vein endoscopic. Okay, cefazolin 2 grams, 3 grams if greater than weight than 120. And so redosing and intraoperative dosing can also be incorporated using those other factors. So that's really, really exciting, and I'd love to talk about that more during the Q&A. All right, so I'm going to shift gears again and talk about other perioperative practices that can reduce SSI. In the middle of the pandemic, the SHEA, which stands for the Society of Healthcare Epidemiology of America, which in my field is basically the authority in North America for a lot of IPAC guidance. It's what we follow, and it really applies quite well to Canada, generally speaking. They came up with new strategies to prevent surgical site infections in acute care hospitals. And what they do, these guidelines have been renewed every few years. They distinguish what are known as essential practices from everything else. So if it's an essential practice, it's because there's high quality evidence to support its use. Now, I won't go through this entire list this morning with you, but if you kind of scan through and you look at this, probably most of this is what you're already doing, because a lot of this has been in place for a while and recommended in terms of, the antiseptic that you use, the administration of antibiotics, the timing of it, all based on at least moderate to high quality evidence. But there's something new that they added to this essential list that actually stood out when we saw this, is they've elevated the use of decolonization using an anti-staphylococcal agent in the preoperative setting for orthopedic and cardiothoracic procedures. Quality of evidence high. And so if you dig a little deeper, they basically state that decolonization, which just for clarity means using intranasal mupirocin, right, which can help to decolonize the nasopharynx where Staph aureus lives, and the use of chlorhexidine bathing to reduce the bioburden of Staph aureus on the skin can be used as the published data supports doing this for 5 days preoperatively to reduce SSI risk. Definitely an undertaking to implement. They talk about alternatives being intranasal providone iodine, and that can be used certainly for people who have a reported allergy to CHG, for example. And then they do note, and I just want to mention this, there are some data now looking at intranasal antisepsis using phototherapy. So basically putting a light in people's nose to actually kill the Staph aureus in the nose. There was a pilot study in Ottawa that came out a few years ago. That's an evolving area and of great interest because you might be able to just receive the phototherapy immediately post-operatively and be able to forego the 5-day treatment that relies on patient adherence. But not as much data to support it at this time. So what's the evidence? How do we know that this is effective? And so here's a look at the meta-analysis from Eli Prensevich. She's actually the editor of JAMA Network Open, colleague of ours, works in Idaho. Essentially 17 studies, and here they are in the forest plot, showing that decolonization strategy prevents SSI in patients undergoing cardiac and orthopedic surgery specifically. It's been looked at in other procedures, but the data is not really as robust. And so it's these specific procedures that are now considered for universal, as an essential practice. There's different options as well. You could universally apply this to all patients undergoing these procedures. Another way is to actually do nasal swabs, see if they have Staph aureus, and then only decolonize those that are positive. But that's an added test and an extra step in your workflow. And in my experience from an IPAC perspective, nasal swabs are great when they're positive, but their sensitivity sometimes is highly variable. And so you may actually miss patients. The trade-off is when you give it universally, you're giving all of this prophylaxis to some patients who may not even be colonized. Having said that, at the end of the day, the most cost-effective approach, as per Shea, and I think this really bears out in our experience, is to just universally apply it and then not have to do the extra testing and follow-up. Ultimately, Staph aureus is an important cause of SSI. Depending on the procedure, it could be up to half of your SSIs. So the impact of this is significant in terms of reducing SSI risk. All right, so let's shift gears and talk about another favorite healthcare-associated infection of mine. I was just joking yesterday that I was asked to assist with our post-operative urinary tract infection problem that we had at Sunnybrook. And we were reflecting on why that happened. I think they were just sitting around a table, and the senior team at my hospital got a report that we were the 10th decile. We participate in NISQIP like you do, and we were the 10th decile of performers as far as our post-operative UTI rate. And within the same week, we had a patient who had a critical incident where they bled out due to a urinary catheter that they actually didn't need. And so this led to a burning platform. And I think they were sitting around the table and they were like, we need to kind of help address this. We're going to bring a few people together to start talking about it. And I, for other reasons, had developed this reputation of being the urine guy. And so they decided to bring me in as well and participate in this project. And so the first step that we did when we looked at this is we thought about when do we need a urinary catheter for perioperative management. And apologies to those that were there last night. I talked about this briefly just to kind of go over it. We still follow the HCPAC guidelines, which are basically very broad guidelines in terms of when we should be using a perioperative catheter. They use very general language. The need for intraoperative monitoring for urine output is basically an example of when you'd use a catheter. So we could probably get 100 anesthetists in a room, and we probably all have different ideas in reading this about which patients we should apply this to and which patients may not need a catheter. And so that was one of the issues that we found is that, well, how do you operationalize this in practice? And can we try to come up with more operational ways of defining appropriateness in our patient population? So in my large trauma center in Toronto, we have over 100 surgeons. It should actually say over 100 anesthetists as well, but there were at least 50 that were really highly engaged in this. We had discussions across all of the surgical services. We utilized WhatsApp, email, just anything to sort of get people to weigh in between cases because we know how busy people are. And then we basically worked iteratively for several months, and we came up with these criteria, which have been published, around who needs a catheter and who doesn't. They're very aligned with HCPAC, but a bit more granular. So anticipated fluid shifts or blood loss, surgery involving the genital urinary tract, that's obviously quite clear. Surgery anticipated to last greater than 4 hours. It's amazing how many procedures just fall under the cusp of that don't need a catheter because they're 3 hours or 3.5 hours. So 4 hours or more being the sweet spot. And this has been studied, by the way, in many other countries like Switzerland that have found that you don't need a catheter for procedures less than 4 hours. And then our surgeon-in-chief had this idea is, okay, that's fine. You have one of those 3 criteria, but can the urinary catheter be removed immediately at the end of case? Because that's actually an extra step to try to be more judicious with catheters. And so indications for maintaining a catheter, so the ones that stay in and they go to the ward, we kind of ask the additional questions about whether or not urology is involved, whether or not there's pre-admission catheter, obviously that's a chronic indwelling. There's sacral ulcers, they need CBI or bladder irrigation. Their comfort care at the end of life, which is actually in the guidelines as a reason to keep a catheter. admitted with spinal cord injury, you need to be careful there in terms of thinking about whether they still need one, or at least it needs to be assessed before it can be removed. And then if they underwent any of these radical pelvic surgeries, then clearly that's going to be something that will need to probably be left in, or at least be assessed about whether it can be removed. I will tell you, and I didn't mention this last night, on the left, completely owned by anesthesia. They just took this up, and it was just like, we're going to follow these, and anything less than 4 hours, it's not going in. And at the end of the case, we're going to remove it if it doesn't, if it can be removed. They basically, on the right side, anesthesia obviously had great awareness about this in terms of whether they could remove in the OR, but it was actually nurses that operationalized removing 1 to 7 using a medical directive. Once we published these criteria and they were agreed upon by all our hospital committees, nurses, a medical directive was implemented so nurses could remove these catheters that did not meet one of these 7 indications. So what was the result? So here's a look at urinary catheter use. First of all, at baseline, we had about 1 in 4 patients that were catheterized during surgery, 25%. And at the end of case, 0 were being removed. That was our baseline practice when we weren't focused on this. As we implemented this new approach and these new guidelines across surgery, we basically saw that the number of insertions dropped gradually. This happened basically over 18 months. And eventually we were down to less than 10% of patients needing a catheter for our procedures using these guidelines. Naturally, as insertions decreased, the number of removed also decreased since there was less opportunity, but still remained higher at about 15% compared to our baseline of 0. When we do this work, one of the powers of having an electronic OR system, which you soon will have, is to be able to start to hardwire some safety checks. Because you implement something like this, you kind of want to know that it's going well and that you aren't creating harm. And so one of the things that we created was a trigger tool. So any catheter that went back in within 48 hours of their OR or of their removal just triggered onto a list so the case could be quickly reviewed to make sure that the reason it got put back in was not related to inappropriate removal. So that's just a nice little piece that I thought I would add. I think when you're doing work like this, you always need to make sure you have a balancing measure, which is basically a measure looking at any potential unintended consequences of your intervention. So the results speak for themselves. When we standardized perioperative use, you can see the gradual reduction in post-operative surgical UTI across our hospital. We went from 10th decile, worst in class, risk adjusted in North America, to first decile, where we've been for the last 8 years. So I'll just offer some additional reflections before I wrap up for the Q&A on how to prevent post-operative infection in general. I think the access to an electronic system is vital because you need to have an ability to do some surveillance and to hardwire some of these changes in place. This simply, a lot of this, what I talked about today, just simply cannot be done with paper-based charts. This is something I'm super proud of. We just implemented this in 2025. So we are part of NISQIP, as I mentioned. So our NISQIP procedures are all here. And basically also infection prevention control at my hospital, so including ID, given our strong relationship between with anesthesia and surgery as well. We do surveillance on a number of key procedures. And essentially we created a dashboard that is visible to all stakeholders, everyone from the CEO to our quality committee to the directors, the chiefs, the physician or surgical chiefs, all of the frontline staff, including nurses and surgeons in the OR. They know basically month to month how many SSIs have occurred, whether it's through NISQIP surveillance or IPAC surveillance. And anything that basically is statistically higher than baseline historically will basically light up as orange. We use orange, I think, for people who are colorblind, because the red, yellow, green system actually doesn't work for those folks. And so the orange essentially is what we use to be able to identify those where we actually have to focus attention. Of course, we have project leadership on these. We have SSI, we have accountability that's built in. So we have surgical leads, anesthesia leads for different programs, and they're sort of accountable for the SSI rates. We, of course, engage stakeholders because we bring these to committees and we bring these to business meetings. So then people provide input. They're like, oh, yeah, that was my case. That was a complex patient. And we actually will bring specific SSIs to see if there were opportunities for improvement. And then we also measure process indicators, right? Things like antibiotic prophylaxis that I talked about to see, how often are we using things like clindamycin, which we know are inferior, and are we unnecessarily using it, for example. And so here's an example of how the power of data. I just picked hip replacements at one of our campuses. This is sort of during the pandemic. We actually, if I went back, you'll see that this was a significant increase. Our orthopedics team was significantly concerned by having an increase in our hip infections. It's a big deal, but we knew about it because we had the data. And so what happened is we convened a group, we met, we said, well, what's going on? We looked at a number of different factors, identified some issues that were actually a bit outside of the hands of our orthopods. It had to do with a lot of the perioperative sort of process that had been compromised during the pandemic. People were being rushed in for the backlog. I'm sure you experienced the same. And so patients were non-optimized. But once we kind of sorted that out, you can see rates went back to our baseline, which is exceptionally low in this program. We had a little blip here, and we were able to address that. And so this is the power of data, where you can actually see your rates every month and react to things in a prospective way. So just to conclude, I think I've hopefully shared with you this morning the opportunity to standardize perioperative practices to reduce risk of healthcare-associated infections. Perioperative antibiotic prophylaxis being really the cornerstone of a lot of what we do for SSI prevention, getting the right antibiotic, the right allergy assessment, the right dose, and the opportunity that's super exciting that you have now to be able to standardize and hardwire those practices into your electronic system. Urinary catheters is another area. It just seems like one of those things that's not as exciting, but it's really important. It causes a lot of morbidity for our patients and can lead to people having long, protracted stays in hospitals, and it's so achievable. The stuff I talked about with the perioperative catheters, I just want to add, that's become an international practice standard. So there's actually a study in Denmark, I mentioned it last night, where over 50% or nearly 50% of the hospitals in Denmark, so meaning of the entire country, have been able to implement catheter reduction strategies with significant results. And so this is something that's definitely ready for broad scale at the level of a province, for example, both Saskatchewan, Regina, and beyond. And as I said, there are lots of opportunities to build in then other more sophisticated tools like CPOE that I talked about and decision support to just try to guide us, make our life easier, guide us to the best practice in a way that we all agree on.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.